talking about risk versus benefits, and then making a decision as a team. It's not, you take it because I say so. No, that doesn't fly. I mean, we need to have that conversation.
Yeah, and I think that's a great point, Christian.
Welcome to the Fat Emperor podcast. I'm your host, Ivor Cummins. We're supported by the Irish Heart Disease Awareness Charity, which advocates a simple CT scan to reveal your CAC score. So, know your score and take action to prevent that premature heart attack. Everything you need to know will be right here.
Hey guys, we're here at Low Carb Houston, and who do I meet? Only Dr. Christian Assad. Great to see you, Christian.
Likewise, pleasure.
And we haven't met before physically, have we?
No.
I don't think so.
Just
no.
Twitter.
Yeah, Twitter. Now, Christian is quite aggressive and outgoing on Twitter to call things as they are. And you're a cardiologist of preventative, interventional?
Interventional cardiologist, but with tremendous interest in prevention, no doubt.
Of course, yeah. And I thought we'd talk through just a few of the big issues in cardiology and heart disease in general. No particular order, but just given your extensive experience and your insights. Mm-hmm. You know, in your journey, a lot of the things you learned early on in cardiology, you've changed your mind on. A lot of the big issues, you've formed new opinions on. So maybe we'll just run through some of those.
Definitely. I think one of the biggest things that have impacted in my life is when I arrived to McAllen, which is where I work. It's the most obese city in the United States. And basically what I noticed is that metabolic syndrome is strongly prevalent in the population. And then as we start looking into the data, as most of your audience will know, it's insulin resistance plays a very important role in this matters. So I started getting this feeling when I'm getting people in their 30s, 34, having STEMIs, heart attacks, blocked arteries, 38 with heart failure. And of course, they're on the medications. Is it making a significant impact? No. I mean, bottom line is no. We need to change and focus. What is it that got them to be as sick as they are in this point? And one of the big controversies, which I will not get into those details, but it's LDL and statin therapy. And I think that when we prescribe statins as a physician, we are, to a certain extent, falsely reassured that the patient is going to be okay. That's not the case. I mean, my patients with statins continue having their issues. And LDL will play an important role in cardiovascular disease, in atherogenic plaque, but we also we cannot ignore everything else that is going around. We cannot ignore the hyperglycemia. We cannot ignore the different aspects of hyperinsulinemia, of basically making it pro-inflammatory. High insulin can make your adipocytes produce more inflammatory cytokines. RBP4, an inflammatory cytokine, which is then going to go to your leukocytes to produce more interleukin 6, interleukin 1, TNF alpha. So we start seeing a lot of inflammation going on. Hyperglycemia is screwing up your glycocalyx, which is basically exposing your endothelium. Insulin alone, when it's hyperinsulinemia, the anti-apoptotic effect, which for your audience is cell death, basically. So insulin on normal levels has a protective effect against apoptosis. When we have hyperinsulinemia, we lose that. So now we start putting a lot of things. So we're talking about endothelium, we're talking about insulinemia, and how insulin is promoting smooth muscle cell growth, so therefore a vessel that is less compliant. We are stimulating endothelin 1 production, so more vasoconstrictions, high blood pressure. Nitric oxide is not being produced adequately, therefore we are decreasing vasodilation, we're increasing pressure. Glycocalyx, inflammation, IL-6. So we start seeing a lot of players in this setting, and just saying LDL alone is going to be, I mean, let's target as well all the other issues. And by decreasing insulin, we will be correcting hyperglycemia. By decreasing insulin, we're going to be stimulating less absorption of water and sodium in the kidneys, decreasing blood pressure, which is playing a very important role in atherogenic plaque and hypertension. So it's not ignoring everything else. We feel falsely reassured that, hey, statin, you're going to be fine. But I'm not telling people not to focus and ignore completely the LDL. But we need to pay equal attention, if not more, to everything else that is happening. So I guess that answers your question.
It does. There's a lot to unpack there, Christian, but you're absolutely, every bit of it resonates. So yeah, so you've got your glycocalyx, which is the kind of polysaccharide protective layer on the inside of your artery wall, then the endothelium, single cell layer, and that's your whole protective structure to prevent atherosclerosis. Mm-hmm. But as you've just described, there's myriad inflammatory markers, myriad damages and deleterious effects that occur that open up your arteries to damage, independent of the LDL vector. And of course, hyperinsulinemia, hyperglycemia, and inflammatory drivers, autoimmune as well, they all act. And they're probably the biggest Pareto, or the biggest part of the problem. And the LDL being drawn in is a part of the problem, but it may actually be the lesser part or the more secondary effect. We're not hitting the big drivers.
Well, here's a question that I've asked multiple colleagues of my, interventional cardiologists, and I asked them, when was the last time that you treated a heart attack on somebody whose only risk factor was having high LDL? Crickets. I mean, bottom line, I mean, and we can avoid the familial hypercholesterolemia, which, I mean, they're even zebras. I mean, it's not something that we see very often. But the fact is, if LDL alone is such a bad thing, well, why aren't we seeing patients with that being their only issue? No, it always comes with a myriad of problems. So, once again, I mean,
and even, Christian, if you tie it back to, as you say, hyperinsulinemia being a big player, not the only player, it's a big player, but we pretty much know now that, especially in younger men, where LDL is a better predictor of future events, high LDL in younger men, it's not so good a predictor at all in older or women, but in younger men, hyperinsulinemia and metabolic syndrome can actually drive cholesterol synthesis and drive up the LDL. So the LDL is a sign of deeper problems rather than the problem. Yeah.
Yeah, and so, I mean, and when we start doing just PubMed research on hyperinsulinemia, there's very interesting data out there. I mean, there's even, publications saying hyperinsulinemia related to cardiovascular events. I mean, simple as that. I mean, you have high insulin, you have increased cardiovascular events. There's a very interesting study from 1961 in which they were injecting insulin to dogs in one leg for a couple of weeks, and then the other leg was only getting normal saline. The leg that I was actually getting the insulin, therefore a state of hyperinsulinemia, atherosclerotic plaque, fatty acid deposition, cholesterol deposition. And the other leg, nothing. Now, of course, you cannot do that in a human, but it shows you something pretty strong about it. And that is from 1961. Where is this research? Why aren't we paying more attention to it?
Well, perhaps you could put your money where your mouth is, Christian, though, and you go ahead and do that experiment on yourself.
Yeah, I'll pass, but thank you.
You get a nice atherosclerotic leg. But yeah, no, that is the 60s, and there's these amazing papers over the last 50 years that prove the point. But you're right, they're kind of ignored because there's no way of tackling with a drug or a good pharmaceutical or a good solution, and therefore no one really is interested so much. An interesting one I put in my talk yesterday actually was a recent one Gudmander sent me from Iceland, a doctor over there, a pal of mine. And I hadn't seen this one before. 2004, incredible. The high LDL people up at 160, over 160, average of 180, 190 milligrams. Huge LDL. But they had the exact same mortality curve and cardiovascular mortality as the low LDL guys. There was no effect with super high LDL. However, when they had super high LDL, but they had high transferrin saturation or iron metabolism issues, then the high LDL people did have a much worse outcome. And it was proposed that iron oxidizing LDL particles and metabolic syndrome driving iron metabolism. But we also have that data for ferritin and of course for insulin resistance. All of these real causes, when you combine them with high LDL, may be worse outcomes. But what's driving the bus? It's behind LDL. It's all of these metabolic derangements.
Ferritin, I mean, again, it could be a marker for inflammation.
Yeah, it is. Yeah.
So, I mean, once again, it does, everything starts pointing towards that there has to be a disruption in the endothelium. And if you pile that up with inflammation, then you could be having then you're having apoptosis also there. I mean, there's multiple things that play or that we can, I mean, it's like, it's surrogates, I understand, but everything is playing a role in plaque. I mean, from inflammation, from apoptosis, from smooth muscle cells being thickened, and then the cells start spreading, therefore permitting more inflammation, and, well, LDL resilience, and it basically facilitates the passage for the nightmare that we see.
Yeah, exactly. And even one thing I learned relatively recently ties directly into what you say, that the LDL doesn't willy-nilly just come through between the endothelial cells. It's transcytosis. It's brought into the endothelial cell, engulfed in a vacuole, brought across with signaling to the other side of the endothelium, and popped out into the wall. Now that's an evolution designed, highly complex process evolved. And yes, transcytosis goes up when you have all these other problems. So you could say, it would make sense, much more sense, that all of these metabolic problems you describe and the smooth muscle cells, inflammatory, they actually drive and signal to bring in LDL. So now, whereas LDL as a dangerous toxic molecule, the system is actually drawing in LDL as a response to injury, which is quite fascinating. You could look at the LDL as more a responding factor than a factor that's hammering your arteries.
It could be. I mean, Dr. Ali spoke about that yesterday. I mean, my knowledge to that hypothesis, I mean, is limited, is what I learned yesterday. Is it possible? Yes. You know what? I mean, I think anything is possible. Meaning, my way of recommending things is very different. The knowledge that I have from what I graduated with is the things that I've going back to the research, me reading the publications, and then making up some conclusions from the data. And I think the whole medical community is finding, well, some alarming things that in discrepancies between what we were taught and what works. For example, if somebody came to my clinic 2 years ago and told me that they wanted to do a ketogenic, low-carb diet because they wanted to reverse all these things, I would say, you know what, you're crazy. It's not going to work. I mean, shoo. And that is completely the opposite of what I do now. I mean, as an interventional cardiologist, I am getting referrals for 24-year-old patients for lifestyle modifications. It's like...
some difference.
100%. And the reason why I say is we need to rethink the things, and when we start digesting all the information and apply it to the reason why we do things, I would ask my colleagues, when was the last time that you were able to reverse disease with medications? My patients came over and over with a lunch box, 20, 25 medications. Nobody says anything. Well, my doctor just increased me with his medication. They did this, they did that. And but somebody says low carb keto or fasting, and the medical community goes crazy, or other people just, I mean.
It is a bizarre double standard, yeah, that you've got something with so much positive evidence growing for decades ago, but also growing every year now, but it's kind of shunned because it's not a proper intervention, it's not medicine, it's a funny diet. But in terms of reversal, you just mentioned reversal, and that's becoming quite topical. Reversal of heart disease. Now, Dr. Faisal on the first day of the Low Carb Houston conference spoke on coronary calcium scanning, and I know you're a big proponent. So we're seeing now a lot of evidence of reversal of soft plaque and perhaps even hard calcification. So what do you think of A, the coronary calcium scan to clarify who is really diseased and not, and get away from the proxies, and B, the idea of working towards reversal with diet and lifestyle?
It's like, I mean, everything. I mean, some people have access to the calcium score very easily and they request it. I mean, sometimes, I mean, if we go by guidelines and things, we need to give the patient the reassurance. So depending on risk factors, family risk factors, is there early history of coronary disease, of heart attacks in the family? I mean, somebody that has a father in 40s having a heart attack, that is definitely somebody that in my book is going to get a calcium score. I mean, I want to know, even though you tell me you're healthy, I mean, I want to see what's going on in addition to a set of labs. I mean, it's $100.
Just a quick break to remind you that this podcast is only possible due to funding from David Bobbitt and the Irish Heart Disease Awareness Charity. For middle-aged people, it is imperative to find out your heart attack risk by getting a CT scan of the heart and your CAC score. The new ihda.ie website has all the scan resources. Please support us by visiting and sharing widely. Knowing your score, you can take action to stop the disease process and save your own life. It can even be as simple as removing sugar, refined carbs and seed oils, i.e. processed food, from your diet. And now we return to the conversation.
So, I mean, but I do have some people here coming to me and saying that they cannot order it or that the physician is having some issues. It's not something that I've encountered. But there's other scenarios in which, for example, people that are on a statin therapy and they want to stop at statin therapy. So, I mean, we need to get the research and make a decision as a team. So if the guy wants to stop completely a statin, I mean, if we go by the research and publications, I mean, if you're below 100 or you're in zero, then I mean, I feel far more if you're metabolically healthy. I feel more strongly about, okay, if you don't want to take the statin, it's okay. But if it's somebody that has a calcium score of 400 and is metabolic broken and already had a cardiovascular event, I mean, I'm not a statin denier, I'm not a proponent, I mean, I'm in the middle. And what I do is I have a discussion with my patients, and sometimes they want to decrease their LDL in different manners, red yeast. I mean, I have had patients that they go for a more pescatarian keto with more wild-caught salmon and red yeast, and I have decreased their LDL from 200 to 100 in 3 months. So, I mean, I'm open to the possibilities, and I think the key is speaking with the patients, talking about risk versus benefits, and then making a decision as a team. It's not you take it because I say so. No, that doesn't fly. I mean, we need to have that conversation.
Yeah, and I think that's a great point, Christian. In the UK, the doctors I know, and Assad Malhotra, the cardiologist, it's shared decision making. So you present the evidence from the trials, the amount of risk reduction you can expect, the number who get a risk reduction out of the number treated, and basically give the information to the patient, and that engages the patient and probably makes them more willing to follow the excellent lifestyle advice that you're giving them, because it's a package. So yeah, I really like that concept. And the calcium score, of course, we know for middle risk people, maybe with a family history, maybe not, the middle riskers who are the majority from the algorithm, 60 to 70% of those guys can go into higher load just when they do a scan and they get the results. So for an engineer, it's so attractive. We find the really dangerous guys, we find the safe guys, and they can relax. Exactly. It stratifies beautifully, yeah. So I think with the new 2018 guidelines last year, though, a huge movement to 2A evidence level rating, we're going to see, and those papers you mentioned, that below 100 calcium score, statin appears to give no real benefit in 10 years. Above 100, substantial benefit. I think we're going to see a lot more use of it, yeah.
And it's focusing, I mean, if we want to reduce and we're focusing, okay, I want to reduce your LDL because my goal is to reduce your chances of having a cardiovascular event, then we cannot ignore that, well, just like I want to reduce your LDL, I want to reduce your triglycerides, I want to reduce your insulin, I want to reduce your hyperglycemia, I want to remove your blood pressure, I want to make you more active, I want to reduce inflammation. I mean, there's so many factors, and the question is, well, medications, well, no, medications are not going to do that. Lifestyle will. And there's tons of research regarding even the use of sauna, meditation, adequate sleep is key in insulin resistance. And many of us, we are stressed, we don't sleep well, and then what we get Ambien, we get a medication to sleep, supposedly, but that is not helping us with our deep sleep or anything like that. So we get medications to try and fix something that is affecting us, but we're just getting poor sleep. I mean, we're not really getting the restorative sleep that we would want, like in that aspect, by taking something like Ambien. And you start getting cravings for the crap food that we should not be eating. So it's once you start looking at it and you just get a bird's eye view, we can see that there's many different interventions by lifestyle that can impact the 5 variables of metabolic syndrome. And we can go with fasting, low carb, keto. We can go with adequate sleep, or episode of high intensity interval training or different exercises, sauna, sleep, and meditation. All of them, tremendous research.
And probably synergistic too.
Exactly.
So more than the sum of their parts. So the patients really need to understand, you don't really pick from a menu. You've kind of got to apply all the menu items together. That's where the big bang for the buck. And I know Dr. William Davis, a cardiologist, had him on the podcast, and he feels so strongly on synergy that if you just get someone to improve their sleep or just go lower on carb, you're not going to see a major result in a trial. His trial in 2009, where he showed half the people reversed their calcification, the other half, most of them, slowed the progression, and he gets no repeat heart attacks with these types of people. He did fish oil, vitamin D, there was sleep counselling, he did a mild statin, and he did magnesium. So he put together a lot of key supplements into a synergistic kind of bullet, and it worked. So myself and Dr. Gerber, we have the 4 S's, reminds me. It's sun, sleep, stress, and supplements. Just to remember the non-low carb, non-exercise things. Those 4. Sauna we didn't have in, but I'm hearing more and more about the benefits.
You go PubMed, you're going to find research from 23 years ago, and literally it targets everything from insulin resistance to blood pressure to inflammation. I mean, the research is there from the Japanese and the research from Finland, and it's pretty hard to ignore. I mean, it's pretty dramatic changes, and the physiology is there.
And just for clarity, these are essentially randomized controlled trials. These are trials rather than mechanistic studies suggesting benefits.
Some of them are.
Some of them are.
Yeah, I mean, but we get what we have, and at the end of the road, I mean, even for heart failure patients, I mean, there's trials of sauna and improvement on heart failure patients. I mean, who on earth prescribes that? Nobody. But we're always very easy at prescribing, so we need to consider something that is not coming in a pill. Something that can actually make you feel pretty good when you go there. Of course, I mean, there's I mean, this is not medical advice, but the point is that if you're gonna try it, you try different temperatures, maybe 5 minutes, see how you feel, and start taking it from there. Me personally, what I do is I do 20 minutes now in the sauna, from 160 to 180 Fahrenheit, but I meditate at the same time. So it's 2 birds, 1 stone. I mean, now, in addition, if you do, sauna, there's even studies out there showing how you get a significant increase in growth hormone production. So,
good.
Hey, you went to the gym, you finish your workout with a sauna and meditation. I mean, do I have research? No, but there's publications. Is it going to harm me? No, and I feel amazing. So, it's getting this type of data, and we can apply it to patients, and it's all healthy lifestyle.
And gym membership generally around the world has fallen in price. There's a lot of availability, so it's not too hard to access. You don't have to be a wealthy person to access these things. You don't need to be a wealthy person to eat low carb keto. I mean, organ meats cost almost nothing, and they're most nutrient
for a liver.
dense. Yeah. And then the high fat mince, which is arguably much healthier than the very lean stuff for many people. That can be a non-premium, quite cheap product per kilogram or pound. So I think a clever low carb. Another thing I love is that eggs are relatively priced low, even free range. Because of the scare of cholesterol, eggs are not really a premium product, and they are nutrient bombs. So all these great things.
There's a funny article, I don't know if you saw in New England Journal of Medicine, a guy that actually was eating 25 eggs per day for 20 years, and cholesterol, nothing. Which, I mean, in medicine it's like, it's the hokey pokey. You put your left foot in, left foot out. I mean, it's like, coffee's good for you, coffee's bad for you, coffee's good for you, coffee's bad for you. I mean, and we go with that with eggs. Eggs are good, eggs are bad, eggs are good, eggs, I mean, make up your mind. So
everyone is utterly confused, and now it is true. And now we've got low carb, keto is good. We've even got a carnivore movement. But on the other side, vegans are saying that meat will kill you, and vegan is the best thing. So the man or woman in the street, there's absolute snowstorm. And our academics and doctors at the top level, like you say, coffee's good, coffee's bad. New study. It's madness. People, I think, need to do their own research carefully and find people who they trust who can do it on their behalf.
Me, the right for somebody telling somebody how to eat ends when the right for that individual starts to decide on what he eats. Shut the hell up. It pisses me off. So the point here is, if somebody with Mexican culture, McAllen is practically Mexico. If I try to convince somebody of those guys to eat vegan in a or vegetarian way, you think I'm going to have luck? No, impossible. It will not happen, not with that culture. So now, I'm open to any way of eating that you want. You want to be a pescatarian, you want to be vegan, you want to do whatever you want. I mean, there are very healthy ways to apply it to your life and improve. Yeah. And I focus on what is the most likely way that I'm going to get you to follow a proper lifestyle, not for a couple of weeks, but for the rest of your life. Now, if you tell me, I've had patients, one, that he's like, you know what, I don't want to eat meat. Fantastic, I'm with you, and let's formulate a vegan, vegetarian diet. Yeah. And fine, I have no problem, but trying to convince somebody that has a Mexican culture not eating meat, good luck with that one. Carne asada and leaving that behind, that's not going to happen.
Very good point. Absolutely, it is in the individual. And as you say, if they have personal ideologies about animals, there's a way to construct a keto type vegan diet. And of course, supplements are important for nutrients you may be low on, but it can be constructed. And you know, vegetarian diets, in terms of attacking heart disease, Esselstyn and Ornish and these guys, there is some truth in that. If people switch from a standard American diet to a relatively low calorie, starvy diet with very low fat, you can actually achieve insulin sensitivity. So it's not what I'd choose ever, but it can be made to work 100%. Once people are well informed and clever about it, or they have a great doctor like yourself advising them. Isn't that right?
Well, if you say so, thank you.
Excellent. Listen, I know you got to go back to your panel, Christian, so great to meet you finally.
Likewise.
Lovely.
Tremendous pleasure.
Cheers.
Alrighty.
Just one quick last thing, we're always looking for people to help share ihda.ie, the website, and down the bottom of the homepage you've got share buttons, and also sign up to thefatemperor.com, subscribe, because we are finding it's very hard to get the right information out there, and increasingly I think search engines and others are optimized for more orthodox medical advice perhaps. Yep. So great if you can help get the message out. Thank you.
Thanks for tuning in, guys. If you're watching on YouTube, you can see my subscribe button in the middle of the screen, a free viewing of the Widowmaker movie on the far right, and myself and Dr. Gerber's book, Eat Rich, Live Long, on the left. Otherwise, please do subscribe to the audio podcast. Thanks.